Safety Lesson 4 covers minimizing patient exposure. Every technique decision you make, the KVP you set, how tightly you collimate the grid you choose or don't choose, is a dose decision. This lesson covers KVP and dose efficiency, MAS control, collimation filtration, source-to-image distance, grids, digital exposure management, and patient-specific considerations. Let's go. KVP controls the energy, the penetrating power, of the X-ray beam. It is the primary controller of dose efficiency in modern imaging. Here is the core relationship. Higher KVP. More energetic photons penetrate tissue more easily. Fewer photons are absorbed. Patient dose goes down. Lower KVP. Less penetrating photons get absorbed in tissue. Patient dose goes up. So as a general rule, maximize KVP to reduce patient dose. The 15% rule makes this practical. Increase KVP by 15%, and you can reduce MAS by 50%, producing equivalent image density with approximately 50% less patient dose. This is the primary optimization technique in digital radiography. The trade-off. Higher KVP reduces subject contrast. You must balance dose reduction against the contrast requirements of each exam. For most studies, higher KVP with lower MAS wins on dose. MAS controls the quantity of X-ray photons produced, and it has a direct, linear relationship with patient dose. Double the MAS, double the dose. Halve the MAS, halve the dose. This makes MAS the primary dose management dial in digital imaging. Automatic Exposure Control, AEC, selects MAS automatically based on the radiation reaching the ionization chamber beneath the patient. AEC is your best tool for consistent, optimized exposure, but it only works accurately when the patient is correctly centered over the active detector chamber. Centering errors with AEC are a major source of overexposure in digital departments. Monitor your exposure index after every digital image. Not just image quality, the number itself. Collimation is the single most effective technique for simultaneously reducing patient dose and improving image contrast. Both benefits come from the same mechanism. Restricting the field reduces the volume of tissue irradiated, which directly reduces Compton scatter production inside the patient. Less scatter produced means less scatter fog reaching the detector, which improves contrast. And less tissue irradiated means lower patient dose. Positive beam limitation, PBL, has been required on fixed radiographic units since 1974. It automatically limits the collimator to the image receptor size. But PBL is a ceiling, not a target. You must collimate even smaller when anatomy allows. Collimation borders should be visible on every radiographic image. If you can't see them, the field was too large. Filtration removes low-energy photons from the beam before they reach the patient. Those low-energy photons cannot penetrate through to the detector. They contribute only to skin dose without contributing anything to the image. The NCRP requires a minimum total filtration of 2.5 millimeters aluminum equivalent for diagnostic X-ray tubes, operating above 70 kVp. Total filtration equals inherent plus added. Inherent filtration is built into the tube itself, the glass envelope, insulating oil, and window, typically 0.5 to 1.0 millimeters aluminum equivalent. Added filtration, aluminum sheets at the tube port, makes up the difference. The half-value layer, HVL, measures beam quality. It is the thickness of aluminum that reduces beam intensity by 50%. HVL is measured as part of your equipment quality control program. Source-to-image distance, SID, affects both image geometry and patient dose. Standard table, SID, 40 inches. Standard chest radiography, SID, 72 inches, primarily to reduce cardiac magnification, but the greater distance also reduces beam intensity at the patient. By the inverse square law, doubling SID reduces intensity to 1/4 at the patient surface. But there is a critical trade-off. Increasing SID requires more MAS to maintain detector dose by the direct square law. Increased MAS means increased patient dose. For routine examinations, use the standardized SID for that projection. Never use a shorter SID than indicated. Closer tube means higher patient dose without clinical benefit. Grids remove scatter radiation from reaching the image receptor, improving contrast. But they carry a significant patient dose cost. The Bucky factor, also called the grid factor, represents the multiplier applied to MAS when using a grid. An 8:1 ratio grid has a Bucky factor of approximately 4 to 5, meaning you need 4 to 5 times more MAS versus non-grid technique to maintain equivalent density. That is a major dose increase. Use a grid when part thickness exceeds 10 centimeters or technique exceeds 60 kVp. Do not use a grid for extremity radiography. The anatomy is thin, scatter is minimal, and adding a grid multiplies dose without benefit. Grid cutoff occurs when the grid is misaligned or used outside its focal range, causing underexposure. A moving Bucky grid eliminates visible grid lines on the image. Digital imaging fundamentally changed dose management, and not entirely for the better. The exposure index, EI, is a number generated by the digital detector representing the radiation that reached the receptor. Higher EI, more radiation reached the detector. The deviation index, DI, tells you how far your EI is from the target. 0 is optimal. +1 means approximately 25% over target. -1 means approximately 25% under. Values outside plus or -3 require investigation. The problem: film punished overexposure immediately. An overexposed film was visually obvious. Digital systems compensate electronically. An overexposed digital image looks diagnostic. There is no visible penalty. The result is exposure creep, a gradual, often unnoticed increase in technique over time. You must monitor the deviation index on every exposure, not just evaluate image appearance. ALARA applies equally in digital imaging. Dose optimization is not one-size-fits-all. Pediatric patients are significantly more radiosensitive than adults. Rapidly dividing cells, longer remaining lifespan, and greater susceptibility to stochastic effects. Use dedicated pediatric technique charts. Reduce MAS substantially for small anatomy. Use immobilization to prevent repeat exposures. Gonadal shielding applies when gonads are near the field. For pregnant patients, never withhold medically necessary imaging. Use low-dose protocols. Increase kVp and reduce MAS. Collimate tightly. Minimize repeats. Every repeat doubles the dose for that view. Monitor your technique systematically, not just case by case. 7-step framework that applies to every exam. Justify the exam. The clinical benefit must outweigh the radiation risk. An unnecessary exam has no acceptable dose. Optimize kVp first. Use the highest kVp consistent with the diagnostic contrast requirements. Minimize MAS. Use AEC when available. Monitor the deviation index. Restrict the field. Collimate to the anatomy. Collimation borders visible on every image. Apply filtration. Verify minimum 2.5 mm aluminum equivalent total filtration. Use a grid only when clinically justified, part above 10 centimeters, or technique above 60 kVp, and shield appropriately. Gonadal shielding when gonads are within 5 centimeters of the field, and shielding won't obscure anatomy. 3 technique and dose questions in the ARRT style. The answer is B. Increase kVp to 92 and decrease MAS to 20. The 15% rule: increasing kVp by 15% allows MAS to be cut in half, producing equivalent image density with approximately 50% dose reduction. Decreasing kVp increases dose. Decreasing SID increases dose. Removing a grid from a lumbar spine study compromises contrast. The answer is B. Smaller field size reduces scatter production, improving subject contrast. Collimation reduces the volume of tissue irradiated, which reduces Compton scatter inside the patient. Less scatter means less fog at the detector. Better contrast. Dose reduction and contrast improvement come from the same mechanism. The answer is C. Document the high deviation index and reduce technique for future exposures. Repeating an already diagnostic image doubles the dose without clinical benefit, directly violating ALRRT. The correct action is to document, investigate the cause, and correct technique going forward. You covered KVP and dose efficiency, MAS control, collimation filtration, SID, grids, digital exposure management, and patient-specific considerations. Every technique decision is a dose decision. Keep drilling in the practice section.